Hello everyone, this is Chadi Alraies from SIF 2024. I'm really delighted to be with Dr. Antony Anandaraj. He's one of the current interventional fellows, and yet in July you're going to be an interventional cardiologist.
Absolutely.
Thanks for being with us, Antony.
Yeah, thank you for having me here, Dr. Alraies.
So you are from High Volume Center, where you have exposed to a variety of procedures, which is really a great thing and a great program. How does SIF fits into your training here?
So I think the timing of it is perfect. Once you cross December of every year, you're almost into the next year, and now thinking like, okay, I'm going to be taking all these decisions all of myself, and what's the right? It's not about what's the next best thing, but it's about what's the safest thing for the patient, right? Yeah. So coming, I think, and attending a meeting like this and getting inputs from all the world experts in the field really highlights the importance of precision PCI and using imaging really as part of your algorithm. I think that is just on time. So the next 3 or 4 months that I've got in training, I'll be trying to pin it into my algorithm and hopefully take that forward. I think that's the most important thing.
And it's very important. You're making a very important point. Is as you said, when you cross December, you are getting comfortable with engagement, guide selection, and stuff like that. Now it's time for fine-tuning your skills.
Absolutely.
Yeah, and then focusing on what is that best therapy for this patient specifically. Yeah.
And do it in the safest possible.
And do it in a safe way. Yeah. During your training, have you encountered any challenging challenge that procedure, communication, and what do you think the biggest? How did you come over it? Because it's going into practice now, as you said, your responsibility increases almost 90% because you have to learn a new job, new system. So what is the biggest fear for interventional cardiologists like you going to the job?
So the biggest fear, I think, is to do with...
say concern, not fear.
Right.
The
concern is really, the complexity of a procedure, correct? If, starting off, I really don't think I should be taking up a highly complex case as my first case. So I think, if I think about that, that's the most important thing. But now that all these things are now fed into my system, I'm slowly developing a process. Going forward, I think at least my plan is going to be start something slow, simple, and then go into the lines of like higher ups, like support and that kind of stuff. So I think
same thing. Also, will bring up something is there's the documentation and the billing, and also the business aspect of cardiology. So it depends on what setup you are going to. Is it a private or a hospital employed or academic job?
Right.
So sometimes you have to do some hustling, which is extra work and extra time on top of all the other responsibility, clinical responsibility I just mentioned.
Right. Yeah. And then, what would be your advice to someone who's like upcoming like me? So going forward, into practice, how do you keep up with all this schedules and time?
Well, number one, as you said, you have to not commit to higher clinical wise. Number one, you have to focus on how to build your practice, how to keep your volume up, not for RVUs or extra income, just to keep your skill going. That's number one. Two is to build a business aspect of cardiology where you're communicating that always with the referring physician, whether it's primary care or it's other cardiologist that is non-invasive who can referring cases to you, so you keep that channel. Three, you have to be very savvy and have a pathway in your EMR where you can quickly write notes, document, close chart on time, because your manager is going to be going after you. Because if you're not closed, it cannot be built for the practice. So this thing has to be keeping in mind. So I recommend for people coming out is to, especially you come out on most of the time on a fixed salary at the beginning, just to kind of give you a nice ramp up. Don't overwhelm yourself, but trying to learn the system really good. Not fast, but good. So this way, when you get busy, you know all the pathways and how to streamline your day every day. Then you have to keep up with activities like this, like coming to meetings and having presentations and stuff like that, which is, I highly recommend for all fellows not to give up, because this is how you keep your portfolio going, how you can get studies recruiting to your center, especially if you have high volume.
Yeah. And then I have two other specific questions. Question number one is, what do you think is the role of your senior partners in a new practice you're going there? And at least my thought process is like I'd like to have a sort of a safety net around me in my first few cases. So, but at the same time, I'm also a person I don't like asking for help unless there is. So there's a limitation within me to say I don't want to really bug this person kind of thing. So, but what would be your approach?
I would say definitely. We just spoke about mentorship, the interview before. Is don't have any regret of asking any question, and there's no dumb question. Why? Because you don't want to get into yourself too deep into a procedure or commitment to something, and then you ask for help. It's a bigger mess to clean up. What I suggest is, especially if even it's simple, you want to do a atherectomy and stand and come out, or share with them, this is my angio, this is the IVUS, what do you think? I'm planning to do 1, 2, 3. Do you agree? This way you make it easy for them to say, oh, you made the right decision, I'm going to say yes or no, or I'm going to just modify your technique or modify your approach. Always I ask my senior partner, at the beginning, almost every case, not because I'm scared or not confident, because I want to make sure I am on the right track.
That makes sense.
Don't worry about, oh, this guy asks me all the time, or
part and parcel of it.
This is they sign up for it. They are really, I think, having pleasure as a senior partner to help you grow as well.
Gotcha.
So don't hesitate.
Gotcha. And then obviously the second step is the cath lab staff by itself, right? Like say I'm used to certain equipments that I use in my training facility now, and I'm going to another facility. How do you overcome? I don't want to be that person who's specific about, hey, I want this particular wire or catheter.
Yes.
Versus they are used to a different system, right?
Yeah,
From a different
but that's a very good question. Yeah, very good point. Especially if you already know the job you're going to and what lab they practice in, and maybe you should ask for the workforce stuff that they work, bread and butter stuff. Let's say they have Boston versus Philips for IVUS, or vice versa, or they have none. You need to bring imaging. So these things, I think, is very important to try to accommodate, because for two things. Number one, it's take too long to get the equipment that you need before once you join the job. It's very, you're not going to ask for any sophisticated stuff. You're not asking for a new valve, for example. You're going to try to, if there's a way you learn the equipment that you're going to be working on in the future in your current fellowship is fine. Even if you have equivalent wire, workhorse wire, equivalent CTO wire, try to practice on that, because I think the difference is very subtle. Two, for the second point too, is we are in a day and age where administration and the finances are very limited. So it's going to be very hard to come in and dictate what you want, and that's going to slow you down a lot. So try to be very flexible, try to accommodate, and I think will be fine, but it's just going to take a couple of cases to get to the new balloons and new equipment and new stents.
That makes sense. And then my final question is, it's a little niche. So I'm interested in coronary, peripheral, and structural, mostly TAVR, at least for the beginning of my career. So when it comes to the peripheral space, at least the center where I've signed up at this particular point, seems like it's mostly falling under the realm of a radiologist and vascular, right? So when I did ask that direct question of, okay, am I going to get a chance to do my peripheral? I don't want to lose the skill that I've developed over time. So the answer is like, yeah, you can do it. So how do you overcome a situation like that? I know it's like a tough situation.
So this is very important because this is life, because it happens all the time. Sometimes peripheral falls under IR, under the vascular. In our center, for example, with some private practice we do peripheral, but we have a very good, strong vascular surgeons too. Number one, if it is as straightforward and you have the support and equipment in the cath lab, I don't think you'll have any problem doing it. The issue comes in if you have a complicated one, or iliac, for example, CTO, and something happened wrong and you have to call for bailout. This is where it becomes a little bit tricky. My recommendation is to kind of be collegial, and via, for instance, you're doing for us a complex case, run it by a vascular surgeon. Say, look, I have a case, and they will support you in terms of, you go ahead, we're aware of it, go ahead, we'll book it in the day that we're around, or you know what, maybe it's better to go with the vascular surgeon. And believe me, this goes a long way, because what happened, the next patient they have in their vascular clinic that you need a cardiac clearance or cardiac issues,
still ask.
Gonna be calling you. Two, advice for everybody is the jack of all trade is good, but to a certain limit, and then you start to develop some depth in your career. You have to be known for something. Nobody can do the CTO of the intertibial and go up and over with the reconstitute the arch, deploy a valve, do a watchman, and then sue CTO.
Right.
It's almost impossible. Try to, for everybody going to, not you only, for everybody in their career, try to find where is your love. What is true love is. Is it valves, is it CTO, and then invest more, because that will bring attention to the partners around you, even in your other private practice group that comes to you, and also administration say, you know what, you are the champion of the valve, we're going to make you the champion, we're going to move forward by making you a structural heart director. But when you are having that breadth, you don't know, I do it all, you do 2 legs a month and then 25 coronary and 2 valves. So far you are stretching yourself thin, and that will help you also funnel down the line the referral patterns to be known in the community for something. Yeah. Well, thank you for asking me the questions.
I mean, it's definitely important to. It's definitely important to learn it from someone who's.
But this is a very important question, and we see it all the time. It's we don't learn it in the books, not in the general cardiology fellowship, but interventional. It's just something you get exposed on day one at the job, and then we expect ourselves to figure it out. And everybody has his own way of cooking that recipe.
Absolutely.
But everybody has his own technique. Well, thank you so much, Antony, for joining us.
Thank you for having me. Thank you for answering all the questions.
Yeah, thank you. Watch the videos and others on SIF YouTube channel. This is Chadi Alraies from SIF 2024.